Hi, everyone. My name is Dr. Bruce Struminger. I'm at Project ECHO at the University of New Mexico, and I want to welcome you all to this second COVID-19 One Health update. And I'm just going to go over a few housekeeping items before we move on to our formal welcome. So first, please chat ECHO IT to troubleshoot any problems with Zoom you might be having. Please use the Q&A feature for questions related to the presentations. The session is being recorded and your attendance is consent to be recorded, so thank you all for that. And we will be making both a link to the recording and to the presentation slides and sharing those with everyone who registered after the session, and we'll make them available on the Project ECHO website and the UC Davis website. There's a link to the COVID-19 One Health Update social media guide. It'll be in the chat, and please check that out. And there are a lot of good tips there on how to use social media to promote and share this, what you're going to learn in this session. There will be continuing professional development, USCME and continuing professional development credits available through the University of New Mexico. There will be a link in the chat at the end of the session. So please claim your CPD, and that's the best way to give us feedback on how you think these sessions are going and how we can improve them. So I'm going to hand it over now to Dr. Jonna Mazet at UC Davis to formally welcome us. Jonna?
Thanks, Bruce. Well, welcome to our second One Health Workforce Next Generation series on the ECHO platform to support academics and our stakeholders in the response to the COVID-19 crisis. We're super pleased to be here with you all today. We're going to hear from our SEAOHUN Secretariat and lead really soon, but I think we were very happy with our last introductory ECHO on COVID. We had more than 900 people joining us from more than 50 countries. And it was obvious that this platform and your strong networks are the people that need to be in the know, are in the know, and can share the most accurate information with your communities. So the last one, if you joined, was very much a lot of information and early information getting out to you. We plan to do these every 2 weeks, but I'm thrilled that this session and the one tomorrow for AFROHUN will be on community surveillance. Of course, we know that key to really getting diseases like COVID-19 under control include contact tracing and community surveillance. And we need to talk about that and how to do it well, but also acknowledge that when we have diseases like COVID that have many asymptomatic carriers and only moderately or mildly symptomatic carriers, doing contact tracing is dependent on having really strong diagnostic and surveillance capabilities. And this one caught a lot of us, most countries, sort of behind the game on that. And so we need to figure out what to do now. So I'm thrilled to hand you over to my colleague to talk about SEAOHUN, welcome you, and then to the experts.
All right, so very warm to the second ECHO sessions on the COVID-19 One Health Update. The SEAOHUN is pleased to co-host the session with the University of California, Davis, and its consortium with the support of the USAID. So I'm Vipat Kuruchittham, Executive Director of the Southeast Asia One Health University Network, or we call ourselves SEAOHUN, with the Secretariat office based in Chiang Mai, Thailand. So our group is a regional network of currently 81 universities in 7 countries, Cambodia, Indonesia, Laos, Malaysia, Philippines, Thailand, and Vietnam. Our university in 7 of the ASEAN member states working together to build a sustainable and competent One Health workforce to effectively prevent, detect, and respond to infectious disease threats, such as the current pandemic that we are all experiencing now. So today the topic is public health surveillance, specifically on the community surveillance. So the public health surveillance is no doubt one of the critical components required to create effective preparedness and response measures to the outbreaks. So through the surveillance, the national governments can monitor cases or current situation and also predict trends for the proposed measures. So today we are excited to have 4 leading experts who will share their expertise and experience in engaging community in monitoring and reporting on health in their communities for both the global and the country perspectives. So I hope the presentation will be useful and facilitate a lively discussion at the end of each talk. So I'd like to pass the microphone back to Professor Watinra Smith, who's a technical director for the USAID One Health Workforce Next Generations, to make an announcement of speakers for today's sessions.
Great. Thanks so much, Pat, and everyone. Thanks for being here together across all of our different time zones. So I'll be the facilitator along with Bruce to be able to keep things moving. So the plan for today is to have 3 short presentations and then to have a short Q&A session, and then to have a couple of country perspectives shared and to go into some Q&A, questions and answers and discussion for the rest of our time together this morning. So please do feel free to post questions or ideas in the chat box. We will be logging those and we'll be able to follow up afterwards to address some of them that we might not have time to do when we're in our live session today. But without further ado, let me pass the baton to Dr. Brian Bird to provide any late-breaking updates around the COVID-19 topic to share with the group and to introduce the community surveillance topic.
All right. Hello, friends and colleagues. It's great to be back with you again after a 2-week absence. It's really great to be a part of this team working around the world, working on this really important infectious disease. And I'm just setting the stage here on community surveillance, but I want everybody to remember that outbreaks begin and end in communities. They begin in individual people that live out in these communities in our countries around the world. And I just want to remind us of that. And that also One Health is an essential part of our work. When we look at communities, we all live in an environment filled with both people and animals, both domesticated animals that we use for food and work purposes, but also wildlife like bats and rodents and primates. And it's how we interact with these animals that's really critical in how we monitor for disease spillover, new outbreaks, and the general situation of health in our communities. So just a global update, very big picture, high level here, just to set the stage. Today, by most trackers, we've crossed 1.5 million confirmed cases of COVID infection around the world. It's now in 184 countries. If we look in our SEAOHUN countries, just south of 10,000 cases at the moment. And something that's become more clear since we last spoke 2 weeks ago, because I spent a lot of time talking about different animal hosts of coronaviruses, the role of bats and other animals in the transmission cycle from these for that virus. What we know now, there's been quite a few more experimental studies done, and it does appear either through experimental studies or reports of contact animals with people, so they're pet animals in their households, that it does look like dogs and cats can certainly be infected. Dogs don't seem to develop much in the way of disease. Cats, though, do seem to develop some respiratory signs and disease, and that includes the large cats, so tigers and lions and the larger felines that we might keep in zoos or come into contact in wild areas. So the recommendations haven't changed from 2 weeks ago. We just have a bit more data now, but that sick persons and their contacts should avoid contact with animals. This will help prevent transmission to those animals and help keep those animals safe. This is very important when we think about conservation of non-human primates. So think about our orangutans that are in the forest throughout Asia and other monkeys and primates. There are some experimental studies now that are suggesting that it does look like chickens and pigs seem to be a bit more resistant to infection. So that's a good news for our food sources. But again, this is a very rapidly evolving situation. So this is the data of today, and that data may change tomorrow. So please monitor the WHO, other websites where you get reliable, factual-based health information for these kinds of informational exchanges. And just to set the stage on community surveillance, this is a nice graph, I think, that shows all the different complicated parts that go into responding to large outbreaks. And what is critical about community-based surveillance is that it touches all of these, whether it's in the early stages of early detection of cases, community contact, right? So I'm looking forward to the discussion from the panelists later, and I'll be around for other questions if you have them. And with that, just some resources in my slide deck when you are reviewing it later, that you can find information backing up the information you found here. So thank you.
Thank you so much, Dr. Bird. So now we're going to go on to Mark Smolinski to share his perspectives and involvement in community surveillance from the ending pandemics.
Great, thank you very much. I'm excited to be speaking to hopefully some colleagues from Southeast Asia, since we've been grounded, and our last trip was to be planning quite a bit of time in the region. So we miss everybody out there, but I'm glad to be participating in this tonight. So I just have a couple of slides to share here. And clearly this is one community that I don't have to explain this first slide to, of a One Health approach, but certainly as we began our work as a newer foundation in San Francisco and building on the idea of pandemics, really looking at the way we were constantly, and you can even see this with the COVID-19, we always look at this yellow curve, and certainly we care about human health, and I don't mean to dismiss that at all, but if 3 out of every 4 diseases jump from animals to humans, it seems we need to be focusing equal effort on that red curve. And we know all these other elements, climate change, deforestation, how we're connected by travel so quickly now. We can see how things spread from China to a global pandemic in just a matter of months. And all of these things are what we focus on in our work on ending pandemics. So we know we can't work everywhere around the world at the same time. And I was glad to see on the opening slide, EcoHealth Alliance, we worked with them early on in developing our strategy of how we would approach bringing innovations in surveillance to disease hotspots around the world. So we have used the map that they created and have updated over time to really look at where we think diseases are emerging based on these models, and then focusing our priorities on these hotspots so that then we can have it expand from there outwards. So since this topic is on community surveillance, I wanted to share with you some of the work we've been doing on ending pandemics across the globe that is directly engaging communities to be part of finding outbreaks faster. And then more importantly, because all of these efforts are two-way communications, it allows us to have an even more rapid response through those same engaged participants across the globe. So I'm only going to talk about 3 of them, clearly 2 of them in the region that most of you are from on this conference call tonight. But Flu Near You in the far left-hand side, we created in partnership with Health Map at Boston Children's Hospital, part of Harvard University, to really test the idea out, can you rely on the public directly to be participating in disease surveillance on a regular basis, where not only can they communicate on a list of symptoms of disease and whether they've had any of those in the last week, but probably equally important, if not more important, telling us that they are healthy. So then within a system, for the first time, you have both a numerator and denominator, and can start to follow diseases like flu, which is a seasonal disease that we wanted to understand more about this respiratory pathogen on an annual basis so that we could better understand when a pandemic threat that would likely be another respiratory pathogen, if not a strain of influenza, we would have better knowledge about how to engage the community, both in helping share information to the public health authorities in signal detection, but equally important in providing valuable information for a rapid response. So in all of the countries that we've worked on, we've taken that idea of direct community engagement and created these two-way tools with the caveat that the tools have to be created by developers within that country in partnership with their governments and often with academic partners as well. And then we help with the process and with providing some seed funding to help test some of the innovative ideas that are often too risky for government budgets, and often academic centers don't have those kind of resources. So using philanthropic dollars to really test out these innovations, we feel has been a really good use of our funds. So one of the projects that you see on the far right-hand side of the screen, the 115 hotline in Cambodia, was created a couple of years ago by developers in Phnom Penh. INSTEAD is the name of the group in the Southeast Asia Laboratory in partnership with the government, responded to the request of the government to have a tool that all 14 million persons living in Cambodia would be able to participate. So long story short, a free national hotline, 115, was created that all telecoms in the country partner with the government to provide free access. So no matter what your phone is or who your provider, you can always use this hotline. After development, it was getting around 600 phone calls a day from the public where you can not only report, but receive information. And now with COVID-19, they are receiving 15,000 phone calls a day from the public, and they've hired 25 full-time operators, and 90% of all cases under surveillance in Cambodia were identified first through the hotline. So the point is building these community-engaged tools to help deal with routine disease surveillance are astronomically helpful when you have a pandemic or other threat to scale up and use for that purpose. So back to the left side, Flu Near You has recently been rebranded as COVID Near You, using the backbone in the 7 years of experience to have that tool ready now to be tracking COVID in the US. And then the last one that I'll just mention there, PAWDD, Participatory One Health Disease Detection. For our group at Ending Pandemics, this is really our flagship project, where community health volunteers are reporting on a regular basis any threat that's happening in the community, both human and animal, and it has led to investigations that have saved millions of dollars from animal diseases being detected early, and we know is saving lives and finding human outbreaks faster, because in the first 6 months of that project being launched in one province, more diseases were detected in the area where the tool was launched in 6 months than had been detected in the entire surrounding area the year before. So we know communities are excited about being part of disease surveillance, and we know they're equally eager to have great information for rapid response. So with that, I'm going to stop and turn this back over to our organizers, but thank you again for the time to share information on some of our projects, and we would love to connect you with our partners in Southeast Asia and other areas of the world to learn more about them firsthand. Thank you.
Thanks so much, Mark. That was really fascinating and wonderful maps and images here to help bring it to life for everybody. So we have one more short presentation to kick us off in our initial session. So we're going to have Dr. Larry Madoff give a short overview of some of his ideas and work linked to ProMED, and then we'll be doing the first Q&A session. So please do continue to note questions or things you'd like to hear more about in the Q&A box, a tool along the bottom of your Zoom in this webinar style format. Dr. Madoff, are you ready?
Can you hear me okay?
Yep.
Great. And I'm going to try my screen sharing here.
Great.
Okay. So thank you very much to the organizers and to all of you for joining us tonight in my time zone at least. And I'm going to talk a little bit about my experience as the editor of ProMED, the Program for Monitoring Emerging Diseases. And it's a pleasure to follow Mark on this talk. Mark is a longtime friend and collaborator, and we've worked together on a number of projects and have, at least from our end, benefited greatly from the association. So thanks, Mark, for that presentation also. What I'm going to talk about is the way that ProMED uses unofficial sources of information. And what I want to say is that we do this from a very One Health perspective, and the type of work that we do, while our emphasis is on a global perspective, the same kind of use of informal sources of information is important at every level, including at the community level. I want to start by just sort of looking at the overall picture of what public health reporting looks like in the world. And it's often a very hierarchical system where people go to see their providers, or people bring their animals to a veterinarian, or a veterinarian comes to them. And these reports from providers of disease occurrence then goes on to local officials in the community. Another source of public health information is laboratory data. And laboratory data, be it human data or animal data, also feeds into this system. And in turn, these local officials may transmit information to the Ministry of Health, and then to world bodies of human and animal health, as shown in this graph. And it's a very hierarchical system, and it has very many advantages. It's a robust system, it's sensitive and accurate, and it's validated because most of the information flows through a professional, and there's or from a validated lab report. It's quantitative, and it can count cases of a disease that's occurring. But there are disadvantages as well. And the disadvantages are that the system can be slow because it takes time for information to percolate through the system. There are incentives for not reporting information, economic and sort of public relations reasons for not reporting. And if there's a broken link anywhere in the system, that a disease entity may never go forward. If there's not a box to check or a laboratory test to confirm something, for example, there was no laboratory test for COVID available when this first started, you can miss uncharacterized or novel diseases. And of course, traditional public health is very expensive. So what I wanted to talk about is informal source surveillance. Sometimes there's some pseudonyms for this that I'll get in. I'm sorry, some other names for this that I'll get into in a minute. But the way that this kind of a system works is that information is gathered and disseminated directly from a number of sources, including healthcare workers, the lay public, ministries of health, laboratories, the media, which is a very frequent source of our information, and world bodies. And that information in turn is pushed out to all of those kinds of organizations as well. And this kind of surveillance, event-based surveillance, biosurveillance, epidemic intelligence, has some advantages as well. It's speedy, it's transparent, And any sort of information can feed into it, including information from clinicians, from labs, from Twitter, from any type of information. And it can identify any kind of event. It doesn't have to be one that already has a category or a name. And in general, these kinds of systems are inexpensive. The disadvantages of these kinds of systems are also, and I think you'll see that this is complementary to traditional public health. The disadvantages are those of potential inaccuracy, the non-quantitative nature, and potential biases that can go into the system. And so I think you can see that these complement the traditional public health system. So our goal, and the goal of this kind of system, is to provide early warnings for outbreaks. And if you go back to the first slide that Mark showed, if you can interrupt that epidemic curve by putting in control measures early in an outbreak, you can prevent its spread, and you can hopefully lower the curve. We do a lot of talk lately about shifting or flattening the curve, but if you can act early and effectively, you can actually lower the curve and prevent outbreaks and perhaps prevent their international spread. So these kinds of systems are also known as informal or non-governmental, unofficial, open source. The World Health Organization now has an effort called Epidemic Intelligence from Open Sources, which uses exactly this kind of data. People also call it rumors, and rumors has a somewhat pejorative sense in English, but in this broad sense, it really just refers to unverified information. So now I'm going to talk about COVID for a minute here, and ProMED was at least among the very first notifications of this disease outbreak. So way back in December, which seems a little bit like ancient history now, ProMED caught wind through social media channels, actually initially, and then verified in a sense through traditional media, an outbreak, an unofficial report from Hubei saying that there had been a cluster of 27 cases of viral pneumonia. Now, Marjorie Pollack, our deputy editor, had been very closely monitoring through a colleague in Asia, a Chinese-speaking colleague, who had been looking at the flow of social media and seeing reports of this kind of information. So it takes that, first of all, that sensitivity, that being open to all sources, it takes an astute observer to find something like this. And then you have to recognize it to sort of separate the important bits of information from the kind of noise that's out there all the time. Marjorie commented on this, and she had been involved in the early detection of SARS, also picked up on ProMED, another coronavirus, and she said that this outbreak looked a lot like the original rumors that accompanied the SARS outbreak. So it was a really a good pickup, and one that I think helped alert the world that this outbreak was coming. I'm just going to introduce you briefly to the ProMED website, and it's at promedmail.org, and any of you can go there and look at information. ProMED began in 1994, and so we're now past our 25th year, and it's grown steadily during that time. But it's a system of moderated emails that's available for free, and anyone can subscribe to. And it's also available on a website and through social media channels. And its goal, as always, is to be an early warning system for emerging disease outbreaks with an emphasis on rapid reporting. So our reports are seen and reviewed by subject matter experts, but aren't peer reviewed in the way that a traditional journal report would be. It's free. We have about 85,000 subscribers now around the world, and I hope that many of you are already subscribers or will become subscribers after this presentation. And we have always had, since the inception of ProMED, an emphasis on One Health. ProMED has always embraced the idea that the world is very closely connected, both across international borders, but also across species borders, and that we share an environment, and that environmental health is very important. We also have a regional network system, and some of you may be aware of our network in Southeast Asia, which was formed in collaboration with the Mekong Basin Disease Surveillance Group, and is called ProMED MBDS. And you can subscribe to that network alone and get reports just on what's going on there. These were our founders, Steve Morse, who is currently working still at the Mailman School in Columbia in New York City, Jack Woodall and Barbara Hatch Rosenberg, who recognized the importance of emerging diseases and the usefulness of the internet in spreading alerts of disease. These are some of our regional networks, and the regional networks focus on the disease in a particular region, sometimes in the languages of those regions, but our MBDS network is in English and focuses on the countries mentioned here. Our staff are located around the world, and it's all done by these people who are subject matter experts in their region or in a particular disease entity. I'll just walk you very quickly through how information flows through ProMED, and then I'll stop and finish up here. So just a couple more slides. But all of the information that goes into ProMED, from media reports, from readers, from official reports, from actively searching for reports, and we have a close collaboration with HealthMap, that the organization that Mark mentioned, also located here, and we collaborate with them on web crawling. But all of the information then goes from a top moderator to a subject area moderator expert. And they actually are sort of where the work happens. And they take the subject, they take the post, they vet it, they review it for possible accuracy, and they provide an expert commentary. So every post comes with commentary. Sometimes if we're unable to verify a report, we'll send a report to this organization called EpiCore, that I'm surprised Mark didn't mention, but one that we worked to develop together. That is something that you may be interested in joining, and it's a widespread organization of public health professionals around the world who can help us verify information. At any rate, this information goes back to the top mod, and then finally is pushed out through our various websites, a website, an app, media reports, and primarily through email. And so there's more information on this. I will stop there and turn it back to the moderator. I know, and we'll have more time for questions. There's more things that I can say, but we'll stop there for the moment. So thank you.
Thanks so much, Dr. Madoff. That was really helpful. And I think as we've been tracking questions, I'd like to come back to at least a couple of them right now, and then we'll have more time to do that after we hear the next presentations that will be coming from some of our folks living in country. So a question for Mark, I think, if you'd like to start, but others, of course, are welcome to chime in both via the panelists, but also in the chat box if folks have contributions. One of the interests and questions was related to how we can encourage the community to really actively participate in surveillance programs. Are there certain incentives or motivational approaches that folks would like to suggest to help really have an active network and to have a good participation?
Yeah, I was actually typing an answer back to Sean Sum. I don't know if that was the question you were reading, but I could begin to read the question, the response that I was typing. I mean, it really differs by, the purpose of the tool and the demographics that you're seeking to include in your surveillance. But, for example, we use participatory surveillance for the first time to see whether it was useful to find outbreaks during mass gatherings. So the World Cup in 2014 in Brazil, everyone who came to Brazil as participants or as spectators, in addition to everybody working there, filled out daily surveys to monitor for rash type illness, for respiratory illness, and other clusters. But at the same time, every time they filled out the survey, which included also whether they were okay with no illness, they got badges and things that were related to the World Cup. And then we did the same thing during the Olympics. In fact, it was so popular that during the World Cup, we had to reduce the time that you could report because people wanted to get the points. It didn't matter because they were saying they were healthy, but we had to put a thing in there so you couldn't report more than every 2 hours because it was so popular that that kind of encouragement got people involved. So people have tried different things. For us, where we have seen the biggest success is that the government has been part of the design and implementation of the community surveillance tool, because ultimately, as a foundation, as not-for-profits, we can do everything we want within the communities that we serve. But when it comes to the disease surveillance, the government is ultimately the only one responsible for the health of its citizens. And so them being part and co-creating these tools has allowed them to be marketed and promoted in ways that even we couldn't predict that would be such a big driving force in getting them adopted, is that literally they're promoted by their own governments.
Thanks for that, Mark. And I think others may have ideas to add as well, but for now, I think we should go and take at least one more question before we go on to our next set of presenters. So for Larry, do you have just brief thoughts to share on the role of serology as compared to other diagnostic methods for conducting surveillance programs that you'd like to portray to the audience?
Sure. So as you all probably realize, most of the laboratory work that's been done around SARS-CoV-2 has been using nucleic acid amplification techniques, RT-PCR, and that's really when we talk about 1.5 million cases, most of those were diagnosed by that method. So there are several methods out there. For finding out, but that helps you. That helps you identify in people who have been tested. It helps you identify cases as they're occurring. But if you want to find out whether someone has had exposure to the virus, serologies become important. And so we know that, and this is all pretty new work because it's only been done, and all of this has been done in the last couple of months. But we know that antibody rises to SARS-CoV-2 after a few days of infection, initially with IgM and then with IgG. And so if you're looking for somebody after they've had an infection to find out whether they've had it, you can look at their antibody response. And so that's where serology becomes useful. And where serology is particularly useful, in my opinion, is in looking at the population. So you can find out, you can look at a cross-section of a population and find out how many people have been infected. And that gives you an idea of how many people had all kinds of disease, not just serious illness or sought health care, but who may have had a low level or asymptomatic infection or not even known they had an infection, but their antibodies will tell us that they have. So if you can do that at a population level, it can tell you a lot about what's happened in the community, in the world, and you can also track the disease. It could also be very useful in trying to find out if someone is immune to the illness. And in the absence of a vaccine, people who have survived, have gotten over an infection, presumably have some degree of lasting immunity to it. And that could be very helpful to know.
Thanks so much for sharing those thoughts. And we can always return to some of these ideas if folks would like follow up during the next Q&A session that we do. So I think that there is an interest in talking about the role of animals in transmission and infection for COVID. So we are going to get back to that one. But why don't we go ahead and hear from two of our country presenters to give us a little context of their experiences and what they're seeing happening with community surveillance on the ground, and then we'll be able to carry on the dialogue further. So Onmar, would you like to go ahead and share your screen and give us some of your ideas and experiences in the context of Myanmar?
Yeah. Okay.
Looks
Can you
good.
hear me?
Yep, we can hear you.
Yeah. I would like to share this Myanmar experience in the community surveillance, engagement in the active surveillance of the community. Yeah, actually, I'm not actively participating in this COVID response, but it's like I have a knowledge and then also some experience from my colleagues, and then also our MOHs, the main actor of this response. Here is like that's community awareness. That's our famous cartoonists make it kind of 14 days quarantine. You have to get it 14-day quarantine is to avoid departing each other for whole life long, and you have to keep yourself not distributing the diseases to the other community and then the family members. That's his effort for the community awareness. And then here is the MOHS sit rep. It's every alternate days they came up with this is, I have to update this. We have 3 deaths until now. It's out of 22 positive. It's like a very much low rate of testing, and then we identify the small number of positive still. And then here is like the number of state and region, how we can get this PUI, and then also the number of facilities and the numbers of quarantine people. And then here is like we have data is like the PUI and hospital quarantine and then the facility quarantines. We have a lot of facility quarantines in here. And here, like this is the COVID key strategy from MOHs. Like in other countries, we start with the containment, active surveillance, and then early detection. And then it's like, as Larry said, it's really important is like risk communication and rumor verification. And then stockpiling is like, it's a problem with like in other countries. Here is lots of returnees coming back from the Thailand, and then also the China. We have a lot of migrant workers working in China and Thailand. So they came back with piles of returnees. And here is like, we make its preparedness. It's like the MOH started with dissemination of the preventive messages, and then like try to revise and then develop the kind of declaration cards. Actually, we have a declaration card already, and then they try to start with all point of entries in border area and then also the international airport. So here is like the initial plan for them is they want to keep the quarantine facilities in big city, Yangon, Mandalay, and Naypyidaw. And then if it's 300 contacts, the initial plan is to make it home quarantine. But however, the problem with this home quarantine, now is 74,000 contacts are quarantined in the more than 5,000 quarantine facilities. So these quarantine facilities are supported by the provincial government and the volunteer from the local community. Here are the kind of educational and all this awareness raising videos from the MOHs. Our state councillors trying to demonstrate how to watch your hand, and this is the kind of famous singers, Go Away COVID, singing the Go Away COVID, such kind of things. And then here is like, I want to tell you that it's like Myanmar community initiatives is really a great one. So I will tell you later at the end of the presentation why this community initiative is so great in Myanmar. So we try to set up the hand washing facility in most of the public places, bus stops and markets. And then social media is very active, especially Facebook in Myanmar is really a good consumption, utilization, and you utilize a lot. As Larry said, there's the fake news and information along this social media. So volunteer groups, they are coming up with the data encoding, and then management, the quarantine facility, and then also the countering the rumors and the misinformation from the social media. These all initiatives are mostly voluntarily and solely done by the privates, individuals, and then community volunteers. Here is like but in here is like this such kind of data encoding and everything is much linked to the MOH's contact tracing and reporting network. And then also here is like a community group, like a Myanmar COVID community, to make it share information and then providing the feedback. And here are the key messages, like how we can transmit it, how many population we can transmit it. And then here is like surgical mask is really uncomfortable to wear, but if not, you have to wear this respirator. And then here is like no one is on the streets, so we can go out, and then it's so boring at home. So, but he said is no one can see the virus everywhere in around you. Such kind of information messages can give. And here is the like we try to make it as like a mapping at the sources. So it's like mapping sources are like we have 33 points of the entry, 30 in border area and 3 international airport. Here is like they make it the fever surveillance and then travel history and then contact record if something happened, and then they try to make it transport support. And it's all collaboration with private public actors, all health staff, volunteer, and then even the ethnic health organization. Here is one of the ethnic health organization trying to provide the health education and then the procedure how to stay quarantined in their area to the returnees from this area. The problem issue is the reliability of this fever surveillance and the travel history and contact records. Sometimes people are giving the wrong information because of this. They are really panic and they try to avoid the discrimination. And then sometimes misinformation, misunderstanding, rumors came up. And then the problem is discrimination. When the returnees come to their own community, even the own community discriminated that you are bringing the disease. Don't come to the community. You have to stay outside the village or the ward, something like that. It's happened. So we try to adjust such kind of discrimination also. And here is the surveillance area. So here, like the community quarantine center for the containment, control, and mitigation, is the returnees, they can stay in the hotel, assigned hotel with their own funding. But for the many people, this like they can stay the big monasteries. Myanmar, we have a big building in the monasteries, and the new development buildings. You can state that all returnees, all the quarantines peoples are stay in the FOC, but it's kind of supported by the religious leader and the local donor. We are practicing home quarantine, but it's not reliable because of the limited knowledge within the family. Even the MOHs came up with the procedure and the policy about this family home quarantine, how to stay home quarantine, such kind of thing, but it's little knowledge. And then also sometimes of discrimination. So that's why many people prefer for the facility quarantine. Hospital quarantine is only for the symptomatic cases. And then we try the community surveillance, trying to make its contact tracing and reporting through again with the community volunteer health workers and then through the web pages. And then here is like in Myanmar, we did in both rural and urban area, community brokers to hand speakers and the loudspeakers for the correct information and reporting, avoidance or rumor. They did it, I think, 2 or 3 times per day by the community volunteer and then also the village leaders. in here again, social media is the main actor. So that's why our state council even has to use their Facebook account to get the correct information, real-time reporting, and then the feedback, and encounter the rumors. And then MOHs and volunteer celebrity groups, they are using for this. Here is from this information, all these things the community surveillance are directly linked to the system with this link. So this one, like you can make it, you can inform the Ministry of Health, like contact tracing. Any people have fever and then any suspected cases, you can report it directly to the Ministry of Health from the community surveillance in the community. We have a lot of issue, and in the leadership is trying to manage this, because like we have to control the panic associated with the rumors and the blaming. And then we have to be very careful about the terminology of lockdown, because our community is traumatized and misunderstood. Of 50 years political instability and the military gender, like we really afraid of the terminology of curfew, lockdown. It's really confused such kind of things. So the government has to be very careful with this lockdown. So we are not locking down until now, just to make it encourage people to self-quarantine. And here is like majority. Our country has many of majority are under poverty lines, hence to false behavior. So they are not, they cannot take care of the disease transmission. Food is much more important than the transmission. So that's why we have to be very careful about this lockdown and the restriction of the movement. And then its government is making the request and appeal. Is instead of using law enforcement and then commanding. And then government is announced to have low income families while waiving electrical usage, and then also providing the food package for the month of April to encourage them to stay at home and not to stop the transmission. I want to talk about the community participation. It is very much great in the community surveillance in Myanmar. Even we have a lot of issues because our community really aware of our health structure is very poor. Our laboratory capacity is very limited, and health workforces are also very limited. We all know about the problem, so that's why we try to participate ourselves, the community participate ourselves in the community surveillance to stop and to alleviate the transmission. And then historically, community is much aware of ourselves, independent and self-reliance, always on board. More than 50 years experience with a responsible government. And then here is like meal and basic needs are higher priority in many people. So that's why government is trying to make its appeal and request and making the people not to be panic and not to be in trouble with this daily basic needs. That's on my presentation. Sorry, I have another one is like even in Myanmar we have small cases, small number of cases identified, but this is really an iceberg because we can test many people. So that's why we have to be very careful every time the community are encouraged to stay at home. And then because of this is only the iceberg. I want to acknowledge all the references, especially my colleagues from World Bank sharing the knowledge for Myanmar community surveillance. This is the end of my presentation. Thank you so much.
Thank you so much, Anmar. That was very helpful, and it was wonderful to hear your perspective on some of the things that are happening there. We're going to go to one more country representative. Again, informal perspective is welcome. Dr. Amanda Fine is in Vietnam and offered to share some of her observations for what's happening there, and then we'll go into our discussion session.
Hello, everyone, and thank you for the opportunity to participate as a panelist today. I participated as a participant two weeks ago, and I will be speaking today from the perspective of a resident of Hanoi in Vietnam, and someone who has been engaged through One Health projects with the Wildlife Conservation Society here in Vietnam, most recently through the PREDICT, USAID-funded PREDICT project with public health partners as well as partners in the animal health sector. We, as WCS, are not actively involved in COVID-19 community surveillance in Vietnam, but do have continued engagement with these partners, and I'll be talking about my experience from a personal perspective today. So just quickly to set the context for Vietnam, it is a country of 100 million people, but we only have, as of yesterday, 251 confirmed cases. About half of those have recovered and no deaths so far. We're there in Southeast Asia with quite a significant border with China, a lot of trade, a lot of connection between the countries. And Vietnam took very early action in the outbreak of what was then the novel coronavirus from the Wuhan area, essentially enacting what is the country's strategy for response to a SARS-like coronavirus in the region. A prime minister's directive came out in the end of January on the 28th, and it mobilized all sectors of the government to protect the health of the people and protect the lives of the people of Vietnam. So this included closing borders with China, and then putting in place the sort of traditional approaches to reducing the threat of spread of an infectious disease, including canceling large events, putting health checks in place, alerting the community in a number of ways to report any cases of fever of unknown origin, especially if there had been contact with, at that time, travelers from China and specifically Wuhan. The order also included prohibitions on the trade of wildlife and required medical declarations at the border. On February 3rd, I flew back into Hanoi after, like many people, being outside the country during the Lunar New Year. At that time, everyone coming into the country was had their temperature checked, and some countries were being asked at that stage to and required to fill out a medical declaration. Those declarations available at the airport and then also very quickly online. The other thing that happened in Vietnam is all schools were closed from early childhood education through to universities for the Tet holiday, and those have never reopened. So schools have been closed in the country since late January. Let me see, I need to advance the slide there. So with those initial actions, Vietnam only had 16 cases that were all linked to a number of initial cases that were due to travel and importation from China and Wuhan. But then in early March, we began to see a second wave of imported COVID-19 cases. And this is the situation we are in now. And the government, as well as a lot of organizations, really ramped up what is essentially community surveillance for COVID-19. This is a Google translation of a message I received on my mobile phone in early March, declaring that the Ministry of Health recommended all people that had entered the country since March 1st to please make a medical declaration. That then became required for those that had entered the country to self-separate at home, self-isolate at least within 14 days after your return to Vietnam, wear a mask, wash your hands in public, and then contact your nearest health agency for advice. They also started to put the health declaration online, and there were a number of apps that one could use to enter that information, as well as a series of hotlines that had been put together in the early stages of the outbreak. Sorry, got to get to where I can advance the slide. Then when there was evidence of cases in Vietnam, the classic alert was a flight from London to Hanoi that landed on March 2nd with a case that reported to the infectious disease hospital here in Hanoi on March 5th with a positive COVID-19 test. This then alerted the government that there were additional cases that were coming into the country, primarily from Europe at the time. That generated a number of changes in terms of what happens at borders and what happens to people coming into the country, and then also an effort to trace all of the passengers of flights, that first initial flight that had a positive case, and then subsequent flights. So I was ended up being directly involved in this situation where a case was on that flight, and the government tracked down all of the people that were on that flight, asked them to go into quarantine. In some cases, they were put into quarantine centers, and then testing was initiated. All their contacts were identified and traced. I had a friend who had met one of those travelers, and they were put into self-quarantine. As was mentioned in the previous presentation, there was an effort to mobilize community units to support the self-quarantine in your residence, but also increase in the number of quarantine centers around the country. When results of passengers on the flight became negative, then orders were put in place to extend the quarantine of contacts only a certain time, and those individuals were released. But through this interaction with the Ministry of Health system, you knew if you are what they called a FO, a case, an F1, a contact with a case, an F2, a contact with a contact of a case, or in my case, an F3, a contact of a contact of a contact with a case. And then it was very clear what you should do. In my case, being 3 steps removed, it was to continue to check my health and report any exposure or any signs or clinical disease to my health district. For people that were 2 steps removed, it was self-isolation for 14 days, etc. One way that we helped with this One Health network was in suggesting and supporting the Ministry of Health in its outreach to the communities. This has been, I guess, unique in Vietnam, where a lot of the initial cases that came into the country were, of course, foreigners coming to Vietnam for travel and on tourist visas or in more permanent settings. And so we helped with the translation of the information those individuals received when they were approached by the health officers for testing. And it explained how you were identified, what was going to happen, and how you were going to get your test results. So initially, in the rush to expand this huge effort on testing, that hadn't been well thought out, especially when you need to communicate with non-Vietnamese speaking citizens. So Vietnam did put mandatory quarantine in place for arrivals after March 15th. It essentially suspended additional arrivals of foreigners from March 22nd and set up screening centers and 45 quick response teams that actually went to your site to do the testing and then the follow-up. So what's happening now and has been very extensive is the contact tracing, then the testing and quarantine of those individuals that need to be put into quarantine. And they've used a number of different ways to get the information out. Again, phone messages with the key information continues to be provided on all of our cellular phone networks. That then directs you both to hotline numbers as well as apps and information like you see on the right here about specific cases and where they have been, again, mobilizing the community to look at that and identify themselves if they have been to these places at the times noted. And Vietnam has essentially moved forward in identifying the major sites where the current clusters are located. And those are essentially in Hanoi and Ho Chi Minh City. A major one now around the Bach Mai Hospital, which is the infectious disease hospital, and really looking to identify people that have had contact. Like many of the hospitals in this region, it's not only the infectious disease hospital. The National Hospital is a main center for a lot of non-infectious disease treatment as well. And there seems to be a cluster of those that have visited the hospital since the middle of the month. And so a couple other outlets that are pushing out the information on the left there is an example of the U.S. Embassy site and its information to citizens. Again, asking citizens and visitors to Vietnam to work with the Ministry of Health in identifying themselves if they have had contacts with these groups. The other thing that's happened, and again, often by volunteer groups, and this is a volunteer group on Facebook that has specifically been putting together COVID-19 information for foreigners in Vietnam, both to provide translation as well as to provide the links that one needs to access the social media and the information that's coming out. And then I think I'll just end there with saying that I've been incredibly impressed with the community surveillance that has been going on and how supported it has also been by the community. The Prime Minister's directives, we're currently in a 15-day nationwide social distancing effort. No non-essential businesses are all closed. And the effort has been echoed, and the directives of the government and the Prime Minister have been echoed. Here you see on the right by graffiti artists to stay home, and then you see that parks are empty and roads are clear, which is not something that is a very common sight in Hanoi, but an incredible effort by the community, both the expatriate community as well as very much the Vietnam citizens that have been working to spread the news on social media and also through these apps that have been created by the government, and then the traditional phone calls, as well as stations within the community where people can contact directly their healthcare providers. Thank you.
Thanks so much, Amanda. That was wonderful and really helpful to see what's happening on the ground and to hear your thoughts from being there. So what we're going to do for the next few minutes is follow up on some of the themes and the questions that have been coming in before and during the session. So we have been tracking some of those, and we will do additional follow-up with the FAQ, the frequently asked question website that we're maintaining as part of these ECHO One Health Community of Practice efforts. So I'd like to first go to Dr. Bird and have him explain a little bit more about what we know about animals, both pets and wild animals, because there have been a number of questions coming in about can they be infected, can they transmit to humans, what's going on with that. The tiger news that came out this week is raising interest and potentially alarm. So can you just tell us a little bit more about what we do and don't know at this point, and then where we might go from there, Dr. Bird?
Sure, thanks. Yeah, so what we know now amongst COVID amongst animals is that what we've known for a long time about coronaviruses is that this group of viruses can infect a wide variety of animal species. That's the bigger group of coronaviruses. Now we know that the SARS-2 virus, the one that causes COVID-19, is in something called the beta coronaviruses, and even a smaller group of those called the 2B beta coronaviruses. And those viruses seem to be reservoired in bats. That's everyone's suspicion. So it appears that these viruses exist in nature in a bat reservoir that then is somehow spilled over from that bat animal into another host. It could be, in the case of MERS coronavirus, a camel. It could be in the case of SARS-1, SARS classic, raccoon cats or civet cats. And now we're learning with SARS-2 that while we don't yet know the true bat reservoir species where the virus lives in nature, or intermediate hosts that might have made the first human cases occur in the initial spillovers, we found that in the houses of people that are infected by the disease, several of their domesticated animals have become infected. It could be their dogs, their pet dogs, or their pet cats, because certainly here in the United States, if you have pet animals, oftentimes you have very close contact with those animals. I mean, I have a small little dog myself, and I like loving on him all the time. So the idea that you could transmit the virus to, or any pathogen to those animals is possible. The issue with the larger cats, so the tigers and lions in the Bronx Zoo recently over the last weekend, that does appear that those animals may have been infected by a person that was shedding virus before they even knew they were sick, that were taking care of those animals. The key thing to remember, though, is that while we know that these animals can be infected, it doesn't appear that, at least to the best of our knowledge now, that they're involved in transmitting the virus back to people. So that's a key thing to remember. You know, as long as sick people and their contacts are avoiding contact with these animals, there should be a low risk of transmission to them. And it doesn't seem that in an epidemiologically relevant way that these animals are a risk to human health at the global level. But again, data will come in. We have to keep watching that situation very closely. There's a lot we don't know, and I think that's important to remember in all of this is we know a lot of things, but there's quite a few things on the virus side we simply don't know. And as more data comes in, please stay tuned, read ProMEDs, listen to your social media channels that might have factual information, and try to stay apprised of the latest developments. Back to you.
Thanks so much. Okay, so hopefully that gives folks a little bit more information on where we're at, and that is an evolving situation. So we do look forward to sharing future updates and having you do the same. This is certainly something where, as many of you are getting used to using this webinar format of Zoom, you're seeing that you have the chat box function, which is a place where you're welcome to type anything, well, professionally oriented, of course, but to stay in touch, and there is a separate Q&A tool in Zoom where you can post questions that we can try and highlight and get answers to as many as possible for you. So thanks to all of you who've been doing that. I'd like to go to Amanda with a question, a follow-up. We've had a few people ask in different ways if there was to be a One Health approach to conducting surveillance that might involve humans, but also livestock or wildlife, domestic animals, you know, would that be something that would potentially go down the syndromic surveillance path? Or is there an idea on how to make that realistic? Because we all do have limited resources. So I just wonder if you have any context you'd like to share on what you think could be done if we wanted to try and at least scratch the surface on taking more of a One Health approach to surveillance in humans and animals.
Thanks. I'd be happy to try to field that question. I think a combination of syndromic as well as more targeted surveillance designed to look for the presence of a virus would be what how we would like to approach a situation like this. We've seen from the examples given today how important syndromic surveillance has been in providing the information that's been critical with this particular disease. And I don't think we should discount the power of that in animals as well. I very much linked to community engagement and sort of participation also in investigations known as participatory epidemiology in some circles, I think really critical. And I see interest in Vietnam. I hear interest across the SEAOHUN network in Asia of looking at ways that can be operationalized. But I think the importance of linking what is happening now in people and those patterns with targeted efforts to mobilize people to report syndromes in animals as well would be one way to look at that, and then follow up testing when you see a potential cluster or accounts that are unusual that need to be followed up, follow that up with more traditional sample collection and then laboratory work. But I think we've seen the power of the participation in this, in the epidemiology, in this outbreak, and other diseases we've all been dealing with over the past 5 to 10 years. But I think mobilizing syndromic surveillance and participatory epidemiology within the animal health sector and the environmental sector really critical as well. Again, we've had really a lot of interest when we work and reach out to the environmental sector, rangers, protected area staff, in terms of their interest in engaging and through, with some of the tools we've talked about today. The critical thing is that information is all pulled together and that you do have the sectors all looking at that, so you can provide advice, insight, and pick up the signals across the One Health triad. Thanks.
Thanks for that. And I'd like to also go to Dr. Phuc, who I think is with us from Vietnam and the Vietnam One Health University Network. If there's any comments that he would like to add on, both with regard to what's happening in Vietnam now or an approach to One Health surveillance. If you're able to use your microphone, we'd love to hear from you.
Okay, thank you very much. So thank you, Amanda. It's it presented some really very good information from Vietnam. But from my side, some is a lesson learned from Vietnam. I think the first very important is under direction of the Communist Party and government Vietnam. They are it's involved at the beginning. So the health system at all levels has been implemented a number of proactive and comprehensive community health action against the pandemic. So actually in the grassroots level, at the district health center, they have a coordinate with a commune local authority to set up a different rapid response team or action. So including health worker, public health, public and private health staff, including retired health professional, even in the students from medical university in whole country also involved in the response team. Of course, it's a policeman, army, teacher, and a representative of community organization. Also, the very important, it's a community member. They are very involved in this response team. So actually, in the grassroots health system, they mobilize and provide its own finance support for the state budget, the donor contribute, or charity fund or from the community member. So they use it a priority for this again, this pandemic. So for other things, at the beginning, it's a Ministry of Health, they gives guidelines for prevention and control of COVID pandemic, very tricky and immediately apply. And they use information technology to improving the reporting system. So promote even from the center to the community level. That's why all people, they can access the information very on time and accurate information, and compliant with government policy, and using its medical declaration accurate for all people and income to Vietnam. So they provide timely data on health and the epidemiological characteristics of all the community members. So for other things, it's a very comprehensive health education campaign to raising the community knowledge, also aware about COVID-19, and to promote hygiene practice, including using the face mask, hand washing with soap or detergent. So it's a community member. They have been asked to advise their related family member who have a symptom of COVID-19 infection should go to the nearest health facility to exam and treatment. So, and some other, I think very important in Vietnam, it's a public health system. It's conducted epidemiological investigation, including early detection. It's infected and suspected case, and very closely it's monitoring and supervise people who has contact with the confirmed or suspected cases. And their implementation of social distancing, I think, very important. It's a maximize for effort to slowing the spread of COVID-19. And we have the network in the community to sentinel testing of patients with respiratory symptoms, and for all general people, also the people contact with a confirmed COVID-19 patient, and even suspected cases should be conducted. And the quarantine is very sticky with all the affected cases, and isolation of suspected cases. They use spraying sanitizer at the potential affected area, even in the around the school or university, and the isolation area. They use spraying disinfection. Of course, it's a medical examination for elderly people and people with chronic disease, and for other vulnerable people in the community has been also very active performed. And lastly, I think very important, it's a confirmed that the COVID-19 has been mostly treated at the local health facility, since we avoid the unnecessary referral and the burden to the specialized hospital in the center. That it's a district health center, they can check for the confirmed COVID-19, and they can take the monitoring afterwards. So that's some lesson from Vietnam. But it's for our network, it's One Health Student Club. They are very active, involved to prepare some involved in the campaign, in the communication in the community. So they are it's a member of Rapid Response Team in Hanoi, also in Ho Chi Minh City. It's a two-big city have a lot of affected cases. So thank you very much for my side.
Thank you so much, Dr. Phuc. The question I'd like to bring up next, and it might be our last question, we'll have to see how we do, but is related to comparisons across the continents. So in this pandemic, right now we're focused on Southeast Asia, but sometimes we can learn a lot from our colleagues around the world. Anyone on this call is very welcome to join us for the AFROHUN session that will be happening later today. But just briefly, I'm wondering, Dr. Bird, could you share any brief comments that you've been hearing from our colleagues in Africa that would help to compare either community surveillance approaches in this particular outbreak or lessons learned from previous ones that you think might be helpful?
Yeah, thanks. That's a great question. I think from my work, so my work has been primarily in Africa, rural parts of Africa, on other diseases than coronaviruses, so the Ebolas and diseases like that. And what I've found there is that community surveillance doesn't necessarily require a lot of technology. And I think that's something to keep in mind. You know, and I saw a few questions from, well, how do we stay connected if we don't have internet and things of that nature? So certainly you can get information from the radio, and many of the communities where I work across most of Africa, the information comes via the radio or through simple non-smartphones, regular SMS texts and things like that. So in some of the countries, and if you tune in tomorrow, you'll hear from one of my colleagues from Sierra Leone, where they've stood up a rapid alert system that uses just simple SMS messaging to alert district medical officers and others that there may be a person sick in their community or in their family with any particular disease. It was built around Ebola. So I think it really takes multiple approaches, and I think that's what's the strength of community-based surveillance is that there's not one solution to how you do it. You don't have to have a super fancy, really slick web-based app, but you can really do it with any kind of technology. As long as we're communicating as people and communicating the health information back to those that need it and can do something with it, that's success. And that's how we overcome these kind of pandemics, is sharing that information and sharing our community knowledge and our community base going forward. Back to you.
Thanks for that. So I'd like to go over to Professor Mazet and see if she has any reflections or comments she'd like to share before we close the session for the evening, or for the morning for many of you who are starting today.
So we're those of us in North America are still on Thursday, but I think everyone else on this ECHO platform is on Friday, and so the AFROHUN session we've been referring to will be much later Friday. If you'd like to join that. Wait, I'm doing it wrong. Wednesday, Thursday. I've got it even further wrong. So it's been a long couple weeks, right, everybody? So anyway, it's still Wednesday here. All of them will be Thursday outside of North America. Sorry about that. But I would love to thank our excellent speakers. We really had a wide breadth here, talking about global tools, digital tools for community surveillance, and then getting to hear from Vietnam and Myanmar about what's happening on the ground for community surveillance there. I do recognize if you're listening, you have some access to internet, but that we are all resources for our communities that may not have great access to internet. And frankly, during this session, I was kicked off because my internet crashed in my community. So, so we do need to, just recognize that there will be limitations. Staying in contact is critical, but we can't be in physical contact. So, all of these things present challenges to us, but I think as evidence of us joining together and all agreeing and committing to be resources for our communities and committing to the communication that is hard right now, but so necessary, we will overcome this and we can do this together. So with that, I'd like to hand over to my esteemed colleague, Pat.
All right, thank you, Jonna. So we'd like to have a round of thanks to all the presenters for very informative sessions. So we learned a lot how we can engage with the community, how to use the information technology and tools to help with their surveillance and monitoring of that. Of course, with that will come of the lot of things of being having overloaded with tons of sources of information, and it's going to be some putting frustration and stress to the community and people who look at and read a lot of news, try to feed out which kind of the true information and misinformation as well. So it's very critical to engage the key people in pushing on the right messages to the public at large. So besides that, also thanks for the participants for the active discussion and Q&As, and also ECHO team and UC Davis team for supporting the sessions. I'd like to encourage all to provide the feedback type of topics and things that you like to hear. As you hear it repeatedly, that we're gonna organize it bi-weekly. So every other weeks for the ECHO sessions focusing on the COVID-19 One Health updates. So we'd like to hear from you or what kind of topics of interest that you may have, or how we can improve and facilitate the sessions to your benefit. So I pass the floor back to Bruce.
Thanks so much. Bruce, take us home.
So the last word is, again, we really want your feedback. So please cut and paste the link to the continuing professional development. Even if you don't want the credit, the CME or the CPD, go ahead and fill it out. There are about 15 questions that will just really help us inform how we're doing and how we can improve. So thanks again to all our speakers and to all the participants. Great session, and we'll have the recording and the presentations out through an email to everyone in the next day or two.
Hey, well.
Thank you. Yeah, stay
Thank
healthy.
you, everyone.
Thanks, everyone. Have a good day.
Thank you.
Bye-bye.
Bye.